So I wish I could start out with efficacy data, which we have none of. And I wish I could start out with the standard research treatment model, which is random assignment to treatment, which we have none of. But this is a story about the implementation of universal newborn hearing screening, and it didn't do anything in the way that it was supposed to do it. And so basically, I'm going to tell you a story about how this all happened. My disclosures are the Asha Foundation, and I'm also on the Scientific Advisory Board for the Lena Foundation. So the national public health goal was to institute universal newborn hearing screening across the United States. We have about 4 million babies born every year in the United States. Unfortunately, at the time the NIH set this goal, we didn't have efficacy data, and today, actually, we have data. Well, I'm going to show you some data. You'll have to make your own decision on whether you think that it actually answers the question of, should we have done this in the United States? Does it make a difference? And my role was, does it make a difference in developmental outcomes? So the slides that you have, I changed them because of what was presented yesterday. Because I had left out some of the parts of the story, and so there are going to be some different slides, and I apologize for that. So let me just tell you that we did a lot of what they talked about yesterday. One of the things was the community-based participatory research, but we didn't know that's what we were doing at the time. This was in 1975. We had an Office of Ed demonstration grant started in 1970, started our parent home intervention for deaf and hard of hearing children. We had 10 families. They were brought into Denver. They stayed in a little house trailer. After the federal grant was over, the Colorado Department of Public Health decided to fund the program, and they operated it with funding through the Department of Public Health, but it was only for people who were rural and mountain families, and only for Medicaid or very, very low-income families. Now, we had decided that we wanted a program that was equitable across the state, in every community of the state, and we decided that in order to do that, we had to have a provider who was skilled, who was an hour commute from every home in the state of Colorado. So what we did is we stuck up one day this map of the state of Colorado, and we put pins on the map of where we knew we had qualified people, and then the rest of the map was completely blank. And we set out, community by community, to go into the communities to ask them to help us identify someone who was willing to be trained. We had no money to pay them because this was pre-Part C. The State Department, we talked the State Department into giving us training money. We identified 150 providers from around the state in every community, and we started training them 4 times a year. They came to Denver. We couldn't pay them for training. We paid their transportation. Most of them, it was just gas money to drive into the state. And they waited until we identified a baby who was birth through 3, who was deaf and hard of hearing, and then they got a baby. But years could go by. I mean, sometimes 6, 7 years could go by before they got anybody. Then, so basically, when universal newborn hearing screening started, and started in 1992, we had a statewide early intervention program since the early 1970s. And over time, we had gotten funding for the program straight from the state legislature. It was a line item in the state budget. We had to appear every year at the state legislature to justify its existence. And they were always wanting to kick it out of the budget. And because we had to do that, we established a statewide assessment protocol because we needed to present data every year to say that it was worth their spending money for us to have this home intervention program. And that was a humbling experience because we started with all of the standardized tests that we had to actually send assessments all over the state on buses and things like that, and train people, and it was an hour for each developmental area. Well, you only see the kids an hour a week, so if you have 10 developmental areas and it takes you 10 sessions to do it, that was really not good. Plus, we used the Bailey that didn't separate out nonverbal and verbal, and it turned out that with intervention, they got worse and worse cognitively, because with the Bailey, cognitive became more heavily loaded verbally. So we ended up with a whole series of parent questionnaires. Many of them were from research studies that had been done on other populations. It turned out that the program became so successful that middle-income families in the urban area actually protested in the Department of Health and threatened to go to the legislature because they couldn't have access to the program. This is the first time we've had a social program, actually, that people beg to have. And the Public Health Department agreed to let them to have families to give access to our trained people, but they had no funding. So in order to do this, this again was pre-Part C, the families were connected with the providers. They arranged some way of getting paid. Either the family could pay for it, which in most cases actually didn't happen. The school district sometimes would pay for it. Developmental disabilities would sometimes pay for something. In some cases where we had no money at all, they worked out a barter system. So we've had everything from babysitting exchange to haircuts to fixing automobiles to a family on the reservation slaughtering their sheep every once in a while to give meat to the provider. And again, we had no money to start this program, so when we started universal newborn hearing screening, we once actually had a small community who talked their local McDonald's into donating 100% of their French fry sales so they could buy screening equipment for the hospital. So we had some pretty crazy ways of implementing services. Our first 2 hospitals used volunteers. We got money for the equipment donated, we used retired people who were volunteers, and we started screening. So in our early intervention program, we did have a trainer model. We had regional trainers that we would train them, and then they would go out and train all the other 100 to 150 providers. We instituted, after universal newborn hearing screening, deaf and hard of hearing sign language instructors who were available to all families if they wanted them. We had the emergence of the Colorado Families for Hands and Voices, which was a partnership with families. They started a leadership training program. They have 1,500 people in the state, families with deaf and hard of hearing kids. It's almost like 90% of all the families who have a deaf and hard of hearing children on their registry. And we had money to provide 1.5 hours of intervention in the home with a highly trained early intervention provider. So in those days, we were spending about $2,500 a year per child. We had, when universal newborn hearing screening started, we had 60 children. In 1994, I got an NIH grant to look at the predictors of successful outcome for deaf and hard of hearing children, but while this was all going on, universal newborn hearing screening started in 2 hospitals in the state, and it started to change everything. So actually, before this ever happened, I should say that what happened was, after I got the grant from NIH, I actually got a call from NIH, from my program officer, asking us if we could run our data to see if we could show that identifying children early made a difference, because they wanted to push universal newborn hearing screening, and we were the only ones they thought might have some data to do that. So the problem was that we weren't smart enough when we did our proposal to NIH, and neither were the reviewers, so we weren't collecting age of identification. And so we had to actually go back and take all of our kids and go back to the hospitals and find out when the children were identified, and it was done retrospectively because we didn't even have the question. And I'll show you what those results are. So we're doing this study. Everything's changing in the state. NIH, everybody in the country is wanting to start universal newborn hearing screening. We ended up getting a grant from Maternal and Child Health to implement to teach states how to do a system to implement universal newborn hearing screening, because we had started and done it fairly successfully in Colorado. I met with the chair of the Colorado State Genetic Metabolic Screen Committee, because they were the only ones in the state who had universal screen, and it was the PKU screen. So we went to lunch with her. I wish I had saved this napkin because she started giving us directions on what we were supposed to do, and we started madly writing this down at lunchtime on all the steps of all the questions we had to answer in order to get universal newborn hearing screening legislated in the state. These were the things she told us we had to do. We had to show that the frequency of disorder merited screening, that we could detect it accurately in mass screening, that we had an acceptable ratio of false positive screening, that the screening programs didn't cause parental harm, that there was effective treatment available and assured, that early intervention improves outcomes, and that costs were reasonable and justified. And at the time, we didn't actually have any data for any of these things, right? But this was what they said that we were going to be asked by everybody who was involved with universal screening, and if we couldn't answer these questions, we weren't going to get it. And they basically told us we didn't have a snowball's chance. We were not going to get universal newborn hearing screening legislated. We also met then with the most powerful lobby for us was the Academy of Pediatrics, and the most powerful committee in the Academy of Pediatrics was Fetus and Newborn. And one of the people in Rhode Island, Dr. Betty Vore, arranged to have a meeting that I was invited to a meeting with the chair of their Fetus and Newborn committee. We were asking them, what do we need to prove to you to get the pediatricians to support universal newborn hearing screening? And they said, which I almost fell out of my chair when they said it, you have to demonstrate that the impact of deafness is as serious as PKU and that the intervention is as successful. That was like a showstopper, right? I mean, and then we went to the National Genetic Metabolic, and they said, in addition, you have to prove to us that you do not cause social emotional harm like cystic fibrosis. So at the time, cystic fibrosis, you die from cystic fibrosis, right? And at the time, what happened is their false positive was so high that even after they told them that they didn't have cystic fibrosis, the stress that remained for those families was so damaging that their relationship with their children apparently was really impacted for a lifespan, because they were waiting for the shoe to drop and for somebody to tell them that actually, no, they really did have cystic fibrosis and they were going to die from it. We had to convince the audiologist, because our audiologist also thought that even if we knew that the child was deaf, we should never tell the parents because we were going to ruin the bonding. So even within our own profession, we had a lot of naysayers to it. We had to have evidence that would prove that the diagnosis had to occur as close to the newborn period as possible in order for optimal outcomes to happen, because otherwise, why do you screen? If you could do it later, then why do you do a universal newborn hearing screening, right? You have to prove that it has to be done immediately. So here's what happened with our the longitudinal data that we had. We did the study that we were asked to do, and we came out with this. So in the first bar, and I don't know if I can. Okay, the first bar is the children identified in the first 6 months of life, and you can see and if I had done this in a pure way, we would have kicked out all the kids who were multiply disabled. I had some kids with a cognitive level of developmental quotient of 20 in here because we took the whole population of the state. And the only reason I did that is because if I took out all 40% of the kids were multiply disabled, if I take out all the multiply disabled kids, I don't have any kids left in the birth through 6 in any of the categories, right? So what we took everybody, and initially, I thought the instrument's not sensitive enough to show any difference. And so we should just go before 18 months, after 18 months, because I didn't think I could ever show anything like a birth through 6 months. My statistician, who knows nothing about deafness really, came to me one day because we were designing this retrospectively, and she said, you know, amazingly enough, we have equal groups in each of the age of identification group by 6 months of age, and I think we should do the research to show that to look at each of those age of identification groups. And I actually told her not to do it because I was sure we weren't going to get the effect. And fortunately for me, she didn't listen to me at all. She did these results, and she comes and she says, you have to look at this. This is absolutely amazing. And I didn't believe it when we first did it. So we checked the data, every data point, like 3 times with 3 different people just to make sure that it was actually accurate. Because if you're seeing here, these are developmental quotients. So this is developmental age, language age over chronological age. If you're early identified, even with all the multiply disabled, cognitively impaired kids, the average of the group was an 80 developmental quotient, which is right at the borderline of normal. If you're identified between any of those other age of identification groups, you were at 60% of chronological age. And there was no difference. You know, I mean, it didn't incrementally improve if we identified you at 19 to 24 months or 7 to 12 months. It wasn't linear at all. It was really a skewed distribution. And it turned out if I gave you, in this room, we didn't even need statistics for it, and I just gave you, without even knowing the question, a whole stack of our results, and I said, divide these into 2 groups, you would have done it because there was almost no overlap between the birth through 6 and the other kids. They were so different from each other. So basically, that is the data, part of the data that the Academy of Pediatrics looked at, and they said, that shows us that we have to do it early. Now, this was just descriptive. There was nothing causal about it. The difference is that I had data, population data, of the whole population in Colorado before universal newborn hearing screening ever started. And then I had population data of the state after universal newborn hearing screening started. And so instead of a random assignment to treatment, the entire state was the treatment, right? You had, first the state was the control, and then the state was the treatment. So it turned out that we had to identify really early, or we weren't going to get the same results. And the early intervention providers were blinded to the results, so we didn't know that age of identification was that important. They were all the same providers. They had the late identified kids and the early identified kids. They were doing exactly the same thing. So this actually is the graph that convinced the Academy of Pediatrics to support universal newborn hearing screening. So remember, they told me, unless you show me that not identifying is as bad as PKU and that you have a treatment that will take away that negative impact, we won't support it, right? So this is what they looked at. Was the first bar, early identified kids with normal cognition. They were over 90 developmental quotient. These are late identified children with normal cognition. And this was the bar that just really shocked them, and shocked us too. These were early identified kids who were cognitively impaired. So all of these children had cognitive impairment, and what you can see that the distributions and the means were identical to the normal cognitive late identified. So they interpreted our results as, if you don't identify hearing loss in the infant period, you create an environmentally caused cognitive disability. And so basically the pediatrician said, this is the same as PKU to us. And this last group are unfortunately the late identified kids who are multiply disabled with low cognition. So it turns out that when we did this study, we only got 2 variables that predicted outcome, cognitive level and age of identification. The age of identification effect was there for every degree of hearing loss, for all socioeconomic levels, for all cognitive levels, for all methods of communication, for both genders and for all ages. It didn't matter when we did it. It didn't matter what the other variables were. We got the effect across the entire population. Then they said, okay, but that's just age of identification. The physicians want to know, we want to know if we screen, if they're born in a hospital that screens, are you going to have the same results? Because they wanted to bypass the intervention. And here's the problem. If you were born in a hospital in Colorado that screens, you had an 80% probability of being at age level from birth through 5 years of age. If you were born in a hospital that didn't screen, you had a 30% probability out of our whole population. But do I believe that screening by itself causes kids to be at age level? Absolutely not. Screening opens the door to identification. Identification opens the door to our appropriate high-quality early intervention program, but of course, people didn't listen to that part, and so, I mean, this is part of the problem. 20 years later, people are now listening, but we had all kinds of campaigns for all kinds of different audiences. Our biggest audience was actually not parents who were going to have identified children. It was parents who were going to have normally hearing children. And basically, we did parent magazines. We did interviews all over, TV things, radio, to pregnant mothers saying, ask your doctor if your baby will be screened for hearing before hospital discharge. You want to know when you leave the hospital that your baby can hear you say, I love you. And basically, that was one of the most powerful messages for the universal newborn hearing screening. It appeared on milk cartons. It was, parents were reading the parent magazine. They were going into their obstetricians asking the question about whether there was a screening program for them. Screening programs make a difference, but not without high-quality early intervention programs. And I can show you that actually that is true, because since we published our results in 1998, there has been no other study published in the United States to show the early identification effect. And the reason for that is because they all looked at just the screening and identification. The early intervention characteristics were random. They just picked kids from all over. They had no control over any of the early intervention delivery fidelity or delivery of service. And so basically, they got no results. And so if you don't have quality intervention, there's no difference between if you early screen or you early identify, your kids are going to be 2 standard deviations below the mean. If you do early identify, you have a high-quality program, you're likely to have 80% of the population with normal cognition at age level. So let me just, in the 4 years, this was like a racing train. In the 4 years that we had the Maternal Child Health Grant from 1996, we went from 2 states to 26 states with initiatives to establish universal newborn hearing screening. We got every constituency on board to support universal newborn hearing screening. But here's the thing, we used such a non-traditional research design to do it that actually, we ended up losing our NIH funding and losing our MCH funding at the end of that period of time. And that's because the reviewers just couldn't accept that an epidemiological population study was the best way to go, and everybody thought they knew how to do it better, even though we'd been working on this for like 20 years. And unfortunately, because of that, I think because they didn't focus on intervention, which was to us the most important, we've never been able to show the effects of besides the Colorado program, but I think now I'm going to be able to publish some of that. One of the reasons we had this runaway train was because MCH and CDC put money into the programs to help states establish it. In 1999, we passed legislation federally to get money to states, and so that allowed other states to develop their universal newborn hearing screening program. Unfortunately for Colorado, we had already done it with no funding, so we didn't get any funding. So we were the only state that got no funding for equipment, no funding for infrastructure. We did get funding for data management. Now, we now have CDC, fortunately for me, Office of Ed and CDC really liked the designs, and so I was able to keep funding over time. And we now have, I think I now have 15 states on board to collect population data on their entire population. This we did last year, but we actually now have 1,000 assessments that we're looking at nationwide. And what we're showing is that the median language quotients across all of these states are within the normal range. So I think we are now going to be able to publish some data in the United States that says if you have quality intervention, you are going to be able to show that early identification and early intervention makes a difference. Now, states differ in their outcomes, and here's 7 states, and you can see that if you look at the outcomes of their entire population, state 7's not doing so well. right? And I can tell you that now what we're beginning to compare the characteristics of the states. There are some things that state 1 has that state 7 doesn't have. Now the question is if we can get state 7 to implement some of the things that states 1 and 2 have, and they're doing really, really well, will we be able to bump up the population statistic so that they are now doing as well as states 1 and 2? And so we're now doing all of these comparisons. The results look very similar regardless of what instrument we use. This is the MacArthur. The last one was the Child Development Inventory. And as you can see, state 3, for instance, has a language quotient of 70, which is in the impaired range, not within the normal range. We also know that children, at least if you're in the state of Colorado, you maintain development within the normal range to age 7. Here's our results with just one of our instruments, the expressive one-word picture vocabulary test. And you can see by age 7, the black line is normal development. Every group, mild through profound, is at age level. And has the same distribution as the normal distribution on the test, the expressive one-word picture vocabulary test. I can predict 70% of the variance in the outcome on every language measure that we do at 7 years of age. And that is pretty amazing to be able to predict at that level. We finally, after years of doing this, have something that we can teach parents, because everything else that we've used that predicts outcome was cognitive level. We can't teach that. Degree of hearing loss, they come with the degree of hearing loss. Age of identification, that's the health system determines that. But now we know, so one of the criticisms of our data is that we never had a maternal level of education effect. And everybody said that's impossible because maternal level of education predicts all language outcomes in every population everywhere. So there must be something wrong with your data, because why don't you have this effect? So I can show you now why we don't have this effect after videotaping thousand videotapes and 13 hours of coding on each of these videotapes. We've divided the parents, this is just one variable, on parent word frequency. The lowest quartile are 984 words, and I can't remember, I think that's per hour. It's a half an hour videotape. So it's 984 words in the half an hour videotape. Middle quartile is 1,245 words. Upper quartile is 1,550. This is by SES, and this is why we don't have this difference, because if you have high SES, so the dark bars are low SES, the light bars are high SES. So let's start here. If you have high SES and you're in the upper quartile of talking, you talk a lot, right? The expressive one-word vocabulary test score for you is above age level at 84 months. And interestingly enough, even if you don't talk very much, if you have, no, this is the low SES. If you have low maternal level of education and you talk a lot, your child has exactly the same vocabulary score as high income. And this is the sad thing about low talking and low income. If you have low talking and you're low income, look at the difference in your vocabulary score at 84 months. It's humongous, right? Interestingly enough, there's some other things, but this is the graph that we show it's like a scale. So if you're early identified and you have high talking and you have high cognitive ability and you have better hearing, right, you have the highest scores and the highest developmental trajectory. Every time we put something on the scale to say your IQ's going, it's impaired or borderline, your maternal level of education is lower, your hearing loss is a greater degree, it drops the trajectory. So we actually have, over this 7-year period, we know what percent actually it decreases the development over time with each of the variables that we've been measuring. We do know that high-quality early intervention programs do have a positive impact on language outcomes, and apparently, even though I can't tell you all of the features of the fidelity of intervention, in our early intervention program, we are teaching parents to talk more to their children, and that's having a tremendous impact it's not just talking more. The quality also improves with the talking more. But it's the easiest thing to measure. We also know that we're effective with Spanish-speaking families. This is a graph that's being used actually for Head Start programs. We use the LENA with this. The Spanish-speaking deaf and hard of hearing kids have parents who talk much, much more, twice as much as the kids who are typically developing in poverty Spanish-speaking populations. And the amount of talking of the Spanish-speaking deaf and hard of hearing kids with intervention is equal to the English-speaking kids who have much, much higher incomes and much higher socioeconomics. But the difference between the deaf and hard of hearing English-speaking and the typically developing English-speaking with intervention, the Spanish deaf and hard of hearing with the Spanish typically developing is actually the same ratio, which says that with intervention, we're making that much of a difference in how parents are more effective at talking to their kids. So we have other data that talks about what happens when you're effective in terms of money. Everybody wants to know about money. State residential schools for the deaf have lost enrollment. Many of them have closed. Center-based programs in the United States are much, much smaller than they've ever been because the kids are going into the mainstream and they are functioning at the levels of their typically developing peers. And I just want to, this is just to show you that over time with assessment, from 1990 to 2012, this is the increase of developmental quotients on the same instrument over time in the population to show how universal newborn hearing screening and quality of early intervention makes a difference. What has happened in the field, and this is really my last slide, since universal newborn hearing screening is that ABR was in research for 20 years before we started universal newborn hearing screening. Nobody did it clinically. Once we started universal newborn hearing screening, the only way you can identify hearing loss is by using physiological measures. So ABR started being used, ASSR started being used. Otoacoustic emissions was not, 20 years of research was not in the field. That started being used. High-frequency tympanometry was in the research, was not being used. We now use that regularly. We now have a diagnostic protocol for auditory neuropathy. We now are implanting kids below at 12 months or younger. We're doing lots and lots of things that we've never done before. But universal newborn hearing screening is one of those things that's really a weird thing because it was like a racing train we were hanging on just to hold on because it happened overnight in the United States, and it's doing the same thing across the world, actually. So